Yes, Ru, boleh.
Okay, today our objective of the discussion today is to how do we assess on the child obesity and how do prevent childhood with obesity, and also how do we manage with childhood obesity. Okay, we start with a case discussion. This is 2 years old boy born term via SVD at 38 weeks plus 1 day with birth weight of 3.4 kilo and current weight is to 20.5 kilo. Matching history, her mother had GDM on diet control, however, personally uneventful. This case was referred by the staff as patient defaulted PSP TCA. PSP means the pegawai zat lah, the nutritional officer at the clinic. At the 18 months old, patient was referred to PSP due to obese on the growth chart. However, patient was defaulted as higher number of COVID-19 cases, one of the reason. Since the patient default clinic follow-up as well as mother claim only will come only once the cases of the COVID-19 reduce. Under further questioning, the child was active at home, not much doing outdoor games activities, and only doing the indoors activities such as walking, also climbing. For the diet history, patient on the formula milk since 1 year old and drinks 8-ounce milks per day, which is 5 to 6 times per day. And then with 3 main meals every day, we include a half plate of the rice together with fish, chicken, and also vegetables. Clinically, patient is alert, active, no syndrome features. For the anthropometry measurement, the weight is 20.5 kilo with a height of 96 centimeter, giving the BMI 21.8 kilometer per meter square. This is the growth chart that we are plotting in the child book, the blue book. Okay, as you can see here, the weight is located at the red region, which is more than 3 standard deviation. And this is the weight. This is for height. Okay, the height is located at the between the +2 standard deviation and 3 standard deviation. And for the BMI, it's located at the red +6. So, based on this case, what is your impression based on the case, and how we advise the parents, and how do you manage this case? Okay, so basically this is a case of childhood obesity. That's a
Rohaida.
Yeah, doctor.
Your line is not that stable, I think. I don't know because I hear you on and off occasionally. Is it only me or how about the rest?
Sekejap jadi slow, masuk okey balik macam tu.
Boleh ke?
Okay. Your line is not that stable. I think you need to perhaps talk a little bit louder. Okay.
Alright.
And you might need to record lah. Okay. So can we back to the other slide? The slide before this. Okay, so what is the impression based on this case? All right, okay. So 2 years old, can someone recaps about this case? Who? Hayati. So what case do we have here? We have a boy. What's problem? Hayati, are you there?
I think Hayati
Hello,
just
dengar ke?
finished the okay. Oh, okay.
Okay, so
Sorry, Dr.
Hayati.
Zani. Hello.
Oh, yes.
Okay, so basically to recap, this basically 2 years old boy lah, born full term 38 weeks with birth weight 3.4 lah. Internationally ada GDM diet control. So otherwise kalau ikut dia punya chart tu, kalau kita tengok, Rohaida boleh buka chart dia tak?
Okay.
So 2 years old, brought by mother to referred by perhaps staff nurse because of the problem with his weight, right?
Weight problem.
Okay, and the weight is like above the red zone, above
Kalau
the
ikut yang
90
berat hingga
centimeter.
lahir, ini BMI kan Ro, yang sebelum ni? Yang berat untuk umur lelaki. So we can see kalau initially 3.4 kan, in between white zone lagi, which is negative 2 standard deviation to +2 lah. Tapi dekat 5 tahun tu dia dah start above the 2 standard deviation lah. Dan sekarang setahun 5 bulan pun dah more than +3 standard deviation lah. So kalau ikut dia punya growth chart ni possible, I mean apa yang cakap, childhood obesity lah doktor.
Okay, so childhood obesity. Okay, any other thoughts? Why cannot it be gigantism? Why is it only obesity?
Because of the
Sebab
height.
rasa satu lagi kita tengok panjang untuk umur dia.
Alright, okay. So unlikely to be giant or gigantism because of the it's only the
dia punya height.
weight. Okay. Yeah, it's only the weight that is increased
Yes.
and is above the line, but the height is following what's the is appropriate to age.
Age.
Okay. So so the first question just now we said this is most probably childhood obesity. Okay, next. How would you like how would you YOU next time? How would you like to advise parents? Okay. Anyone? Faiza, you think this is childhood obesity? How would you like to advise his parents? Or is it advice first or is it history first or what? Faiza, can you hear me? Karen?
As for me, I will actually get history before advising the parent. So maybe I'll say I will first get a proper history and then examine the patient. Then
What history you want to know?
antenatal history, perinatal
Okay,
history,
we got that antenatal. His mother got GDM.
family history,
What else? Sorry?
whether there's any early diabetic,
Diet history, receipt. We want to know about diet history. Do you
any
think
genetic
parents?
disorders, syndromes
Yes, okay.
in the family.
Lagi?
And then as for the child itself, his diet, sleeping patterns, screen time,
So diet of the child, any genetic abnormalities in the family. What else? Mother's occupation. Do you think is important?
yes, for like
Who
psychosocial.
feed him? Who feed him? It will be his mother, right? Usually. So like for the most of us, do we have time to cook 4 times a day for our baby? So usually what? Mothers that have time or working from home, you know, that got time to actually feed their babies 4 or 5 times a day. Okay. So from the history then, can you only manage this case? Okay, Rohaida, tell us.
Okay, so we are going to manage this case together. So first we go to the definition of the obesity. So basically the obesity is defined as excess of fat. And then the BMI does not measure the fat directly, but is considered a practical alternative to directly measure the body fat. Okay, and the body mass index or BMI is the accepted standard measure of overweight and obesity in children more than or equal to 2 years old. Okay, for those less than 2 years old, we use the weight for height measurement. Okay, for the BMI, for the normal, we use the more than fifth to percentile to less than 85th percentile, which is 84th lah. For the overweight, the BMI is more than 85th percentile to less than 94th percentile. For obesity, those who are BMI more than 95th percentile, And then for the severe obesity, we use the BMI more than 120% or BMI more than 35 or whichever is lower lah. This one for the age more than 2 years old. For the less than 2 years old, we still use the weight for height. For overweight is more than 2 standard deviation, and for the obesity, weight for height is more than 3 standard deviation. Okay, so we go for epidemiology. So in Malaysia, 1.65 million Malaysian school children are expected to be obese or overweight by 2025 if we don't do anything. And overweight and obese children are likely to stay obese in adulthood and more likely to develop non-communicable disease like diabetes and cardiovascular disease at younger age. So just imagine if in 10 or 15 years later, we will meet those who are at the 20s, develop diabetes and also cardiovascular disease. So we manage those in the younger age, okay, if we don't do anything. So overweight and obesity as well as their related diseases are largely preventable. So prevention of childhood obesity therefore needs for higher priority. Okay, this is the prevalence of overweight and obesity in Malaysia. So the higher prevalence is for the national prevalence is around 14.9% for obese and also 15.6% for overweight. For Kelantan, it's not at the lowest prevalence, which is around 13.7 for the overweight. Okay, for obesity, it's the lowest prevalence is Sabah lah, around 9.9%. Okay, so we go to the etiology and risk factors of childhood obesity. So for when we face with the childhood obesity, we need to think of these four risk etiology lah. The first one is the environmental factors. The second one is endocrine, genetics, and also hypothalamic obesity. Usually, the environmental factors, the children will have a constitutional obesity or constitutional obesity lah. Okay, we go one by one. For environmental factors, usually we look into the incident lah during the pregnancy itself lah. During pregnancy, the maternal obesity, the gestational diabetes, pre-gestational diabetes lead to the increase in the childhood obesity. For birth and also the first 2 years, usually those who are delivered with low birth weight and then having rapid weight gain during the initial neonate and also infant period, usually associated with the childhood obesity. For the normal and also large gestational age, usually we look into the breastfeeding practice and early feeding practice lah, usually when the weaning started in the child. And for the beyond 2 years old, usually is related to the lifestyle. And then for dietary, this is the current with the fast food, with the because our nutritional food is much more much more expensive nowadays. And so usually the child will have intake more than they needs lah. And then of course the sugary drinks. And then the television and also video games currently replacing the outdoor games that we used before kan, main kat luar. Tapi sekarang anak-anak kita banyak play with video games, with banyak sekarang kan, with the television, with the handphone that replace the outdoor game. And then the sleep, okay, those the TV, telephone, and then the child become tidur lewat malam kan. So evidence suggests that association between the shortened sleep duration or irregular sleep schedule and obesity. So those yang tidur lewat malam, dia akan ambil makan waktu malam and then end up with obesity. And of course the physical inactivity and also sedentary behavior. Okay, and then the other things is that we are not to be missed is medication. Usually the anticonvulsant, anti-diabetic or antipsychotic will lead to the childhood obesity. Okay, so when we talk about the obesity, we will talk about the health effect to the child. It's either physical effect and also emotional and also psychological effect. We can see the lots of case of diabetes, high blood pressure, high cholesterol among the child, and also it leads to the sleep problem. And lately we had a lot of case of bullying, maybe not because related to the obesity, but obesity also can affect the children. They can have a low self-esteem and non-confidence. They might develop depression, discrimination by their own families as well, and also bullied by friends. So when we face with the childhood obesity, what are the history that we are going to we need to take is, of course, the age and of onset of overweight, okay, and then medical history, the prenatal period, the neonatal, and also development, and also the review of the symptoms lah. Either patient have any presence of the comorbidities, also medication and drug history that we list just now, and the important part is the family history, okay? Because those we if we face with the childhood obesity, we need to categorize the child whether have high risk or low risk lah. Those who are having obesity in the first degree relative, either parents or siblings, they had a high risk group of getting obesity. If both parents are obese, the child's risk of being obese as an adult is increased 6 to 15-fold as compared to a child without obese parents lah. Okay, and then of course dietary history, the breastfeeding because
Rohaida tadi, do you answer Kimi punya soalan tu?
saya tak baca sekejap
Medication yang you sebut medication tadi that can cause obesity, is it medication taken by the mother during antenatal or is the medication taken by the child?
medication taken by the child.
You mean all that medication?
Yeah. Ini
But then the
Yeah.
child is only 2 years, right?
Okay. By the mother and also the child itself lah. Dua-dua.
So you mean that if a mother taking paroxetine, then the chances is the baby can be obese. Is that right?
Yes.
Are you sure?
Tapi yang banyak saya baca tu yang child lah. This one kita fokus kepada child itself lah. Usually because we are talking
older
about
child lah, older child. I mean not this child lah. Maksudnya older
yes.
child, those that
child,
12 and below. Older
yes.
child, those that 12 and below. This is among the medication that can cause weight gain. Right? Okay,
Yes.
so we just need to be aware if there is a child, you know that actually on this medication, because I don't think mother take all this, the child can be obese. I don't think so lah. So, but then we know that in our case, that is not the case, tak apa lah. But then we have to know that this among, if we have a child that is obese, this is among the medication that we have to take note of. Okay? Okay, you can continue. Okay, Kimi? Okay,
Okay, and then we go to the dietary history. There are a few there are few studies lah shows that those who are breastfeeding more than 6 months, maksudnya exclusive breastfeeding, less likely to develop obesity later in life. Okay, so we need to encourage the breastfeeding, and then of course nowadays there's a lot of restaurant, fast food, sweet drinks. Okay, also leads to the obesity. And then
early weaning leads to obesity
ada study dikata sebab early introduction of the solid food which is less than 6 months.
Alright, okay. Okay, thank you.
Okay. And then breakfast as well. Okay, skipping breakfast is associated with increased obesity in children despite perceived decrease in daily calorie intakes. And then the children who skip meals are more likely to be obese than those who eat more frequently, and also unhealthy snacking and a parents feeding style. Okay, and then we need to know the activity history, what type of the physical activity that the child do, the type, duration, frequency, and intensity of structured physical activity like sport or unstructured play lah. And also, of course, nowadays sedentary behaviors like how many hours that spent watching television, games, computer, telephone, internet-based activity. And then psychosocial history, is there any complication like depression, school and social issues, okay, any binge eating or emotional eating. For economic challenges, there are, because currently our vegetables are increased in price kan, naik harga mahal, and then we can see that nutritional food are more expensive compared to less nutritional food. So usually they tend to buy the non-nutritional food lah compared the nutritional food. Okay, and then the cultural factors, whether the patient's perceptions toward the child's weight, and also excessive anxiety about the child's weight. Okay. So we go to the weight and height assessment. Okay, I think this one biasa kita dah tengok ni kan. Okay, so supposedly ideally we need to measure the weight and height of the infant status every time they come to the clinic, or at least annually lah. Okay, we can use the one the growth chart that available in the child book. And then for those who are more than 3 years old, we measure the BMI. So for other measurement, it's not well not well established. Like waist to hip ratio, there's no definition developed for children. For the waist circumference, the percentile is only developed at the overseas country lah. And then the triceps skin fold thickness, muscle circumference also less accurate. For the imaging, it does not contribute to clinical care. Okay. Okay. Everyone follow ke? Boleh ke?
Boleh, boleh.
Okay, so next we go to the examination. Okay. Okay, what we need to examine in patient when we see a patient with childhood obesity. So first of all, we need to measure the blood pressure. Yeah? Measure the blood pressure using a proper size cuff, because we know that childhood obesity related to the high blood pressure. And then we can plot in the BP chart lah. And then we need to plot the stature and also height velocity, because usually the exogenous obesity or constitutional obesity, the most obese children are tall. They're usually tall and obese. But if those who are endocrine also and genetic causes of obesity, they're usually associated with short stature. So they're usually short and obese. Okay. And then the height velocity may be slow in the children with endocrine causes of obesity, including hypothalamic pituitary lesion. And then, of course, the general appearance, we look into any dysmorphic features, because the obesity is not only because of environmental, like I just said just now. It can be due to endocrine causes, can be due to genetic causes. Okay, so we must look into any dysmorphic features. And then assessment of the fat distribution. Okay, whether the buffalo hump, the distributed at the trunk or peripheries, or abdominal obesities, and of course the general assessment of the mood, either depression or anxiety. Okay, and then we look into the head, eyes, ears, nose, throat. Okay, and then skin and hair, because hypothyroid also can lead to the obesity. So we can look into the dry or any coarse or brittle hair. Okay, abdominal striae or acanthosis nigricans, or any hirsutism lah for PCOS. And we look into the abdomen as well. Okay, so for musculoskeletal, We look at the any edema, polydactyly or small hand or feet, any gait abnormality like Januvarus or pes planus. Okay, and then we need to evaluate the pubertal stage because precocious puberty as well can lead to the obesity. And then, of course, the developmental assessment. Okay, so after we look into the risk factors, okay, like we discussed just now, okay, if those, we need to classify whether the child have a risk factor to develop obesity and also non-communicable disease later. So we need to classify whether the child has risk factor or not. So we need to further discuss on the family history, okay, because those who are overweight, and those who are child with overweight with no risk factors, we can start for the lab investigation, we can take the fasting lipid level lah. If those child with who is overweight with risk factors, either one risk factors, either family history of obesity related disease, high BP or elevated lipid level or tobacco use, we need to take the fasting lipid level, liver function test and also fasting glucose level. For those who are overweight, either risk factor or no risk factor, so we can take the fasting lipid level, ALT, AST, and also fasting glucose level. Okay, when we need to start to screen the patient, we can start at the age of 10 years old and we can repeat every 2 years. Okay, and additional testing based on the clinical finding that may be warranted lah. If we can see patient had features of the hypothyroid, so we can take the thyroid function test. If patient had symptoms of obstructive sleep apnea, we can take the polysomnography testing. And those were features of PCOS, so we can take the testosterone. And for syndrome obesity, we can take the relevant genetic testing lah, like FIV ataupun methylation test lah. Okay. Next, for imaging, radiographic evaluation of overweight and obese children is directed by findings on the history and also physical examination. So not all of the child with obese, we do the radiography evaluation lah, based on the history and also physical examination. And the plain radiograph of the lower extremities, if we see patient with abnormal gait, hip or knee pain that we suspect of slip capital femoral atrophysis, or with a pace Januvarus just now, bowing tibia, so we can order plain radiograph. Or abdominal ultrasound is those who are having gallbladder disease, fatty liver or PCOS. Okay. So we go to the approach of principle of approach those who are in a childhood obesity. So basically, this is the most challenging. Okay, I think not only primary care, but those in the pediatric endocrine, because manage obesity is a complex, it's challenging because we need to deal with the habits, behavior modification, diet, and also physical activity with kids. Okay, so the obesity is a complex disease, and the main objective is to try lasting change in habit of children and family. Okay, changing habit is not an easy job lah, kan? And then strategies should be age appropriate, enjoyable, and cause no adverse effect. And management should not constitute an additional burden, but rather provide a way to alleviate the existing one. Okay, so I think the most important thing is to prevent obesity lah. If those who are obese, to prevent obese, kan? So there's a lot of banyak list kat sini, tapi basically that we can classify is that we need to change, we need to advise parents on the behavioral modification, diet, and also activity. So for the diet, we can improve with food choices, okay? And then we can for prevent, we can introduce the lean meat, poultry or fish later in first year of life, okay? And then promote breastfeeding, introduce of infant food at 6 months with focus on cereal, fruits and vegetables. Okay, avoid sugary drinks. Okay, and then family approach like a scheduled meals like we discussed. Okay, because the study shows that those who are having dinner or having meals together more less likely to develop obese lah. Reduce risk of obese about 60%. Okay, and then frequent snacking to be avoided, and the activities for the child we encourage 60 minutes activity per day for our children. Encourage walking to the school and also limit the use of mass media. Okay, this is based on the age lah. We can see we can you all can read later lah. Okay. So for the American Academy of Pediatrics, they suggest the simple like yang mnemonic lah kan. 5210, which is eat 5 or more fruits and vegetables. Ini easy untuk kita bagi tahu kita punya parents lah. 5 or more fruits and vegetables, 2 hour or less recreational screen time, 1 hour activity and 0 sugary drinks, and water is the best. Kan? Plain water is the best. Okay, senang. 5, 2, 1, 0. Okay. And then when we talk about fruits, we can use the suku-suku separuh, awak pingat suku-suku separuh, or there's with traffic light punya traffic light and also our pyramids, we can explain to the parents lah. Okay. And then this is the new recommendation by the American Academy of Pediatrics. The screen time for kids is the long time no screen time before 2 rule is out. Okay, here is the latest recommendation for those who are 18 months or younger. There is no screen still the best, except for the video chat or with family and friends. Okay, for 18 months and 2 years old, limit screen time and avoid solo use, but choose the high quality educational program and watch with kids to ensure the understanding. For 2 to 5 years, limit the screen time to an hour a day. So start after 2 years to 5 years, boleh bagilah an hour a day. And parents should watch as well to ensure understanding and application to their work. And 6 years and older, we can limit masa. Contohnya kita bagi ke anak kita, okay, satu hari boleh tengok how many hours je. Let's say 2 hours ke, kan. Sebab sekarang pun PDPR kan. But don't let the screen time the affect sleeps, exercise or other behavior. Okay, this is the physical activity lah, and that we mentioned just now. Okay, at least for children 1 to 2 years, kita ada activity at least 180 minutes ataupun 3 jam. Betul tak? 3 jam satu hari kan. And then, okay. And then for children 3 to 4 years old also, we advise for physical activity 180 minutes as well lah. Okay, so ni sama juga. And then to have a good quality sleep. Okay. Okay, so this is
Sekejap. Haida. There is a question about the formula milk. Okay. I think whatever it is, when we refer children with obesity, we do need the multidisciplinary. And the nutritionist or the dietitian, they will actually look at whatever input that the baby or the child have, and they will actually modify, okay? Because usually if it after 18 months, formula milk or whatever is not the main energy. You know, this is only for, we say, for the bone and everything. So maximum it should be only like 2 glasses per day. Okay, because I know that in our society sometimes we do give children milk as a main calorie intake. You know, we do have this kind of problems, whereas it should be by 18 months, milk is only for we said for the bone and everything, it should be only 2 bottles or 2 glasses per day, not for them to fill their belly with. You know, they should fill their belly with carbohydrate, protein and veggies. not with milk. Okay. All right. Anything. I mean, we have to remember that we need to Chia do Chia, what document do you share with? What is it about?
The attendance.
Attendance form. Okay,
Attendance
sorry.
limit.
I ingatkan. I thought it was like something to like. But the thing is like when you sit down with parents in this case, because he's only like 2 and something, we can do something still. So the major thing is about the calorie thing. Okay. The major thing is about the calorie, the intake, how much that he take in. So everything, you know, we have to actually calculate again based on his requirement plus what do we need to cut to actually reduce his weight. Okay, because he takes a lot. He takes more than whatever he needs. So we do need we need parental counseling, we need motivational interview. This is not with just like 2 or 3 consultation, you got it. No, it will be like, I don't know, 2 years follow up, you know, every 3 months, perhaps stricter, and you will need to say that for every weight loss or for not gaining weight, there will be star chart, there will be some gift to the parents, to the kid, because this one it cannot just like kurangkan makan, janganlah berhenti. No, it cannot be that. You need to be like carefully planning for every stages, you know. And dietitian input is important, child psychiatrist or child psychologist even sometimes. Okay, and we need a consensus between parents, and both parents. It won't work if the mother said, okay, she agreed that the baby is obese and has something to be done, and the father said it's okay, because the father will give the food even if the mother did not give. Okay.
Maaf ya, saya nak tanya satu soalan tentang suku-suku separa boleh? Do we have a standardized pinggang nggak untuk anak-anak atau kanak-kanak according to the age? Or we go by, because adults we have adults usually is easier because the pinggang memang plate memang macam tok kan. But how about the kanak-kanak? Oh, kita pakai tangan sebab sometimes we counsel adults by using tangan. Satu tangan,
I think
satu
for
suku.
kids also the same thing lah, Ngo. You use the hand,
Use
the
hand.
child's
Okay.
hand. I mean, by protein and all that, right? They say the size of the palm of the hand. Yeah.
Okay. So I have to buy the.
But usually dietitian, they will calculate the weight. They will calculate the weights, the need and everything. They will come out with certain calorie thingy, you know, because I mean, we know a little bit, we know the principle, but usually that thing, okay, what to give, and also the way of cooking and everything, and also like making veggie as a snack food, you know, like cut small veggies, and also fruits. So the thing that we need to actually first is recognize that there is a problem. Okay, by these 2 years we got to recognize that there is problem, and we need to transfer this knowledge or this insight to the parents. Your child has a problem, and the problem need to be tackled quickly. It need your cooperation. That's the things that we want to impart to the parents. And we need to involve all the relevant multidisciplinary that we have. Okay, because we know that if this thing keep going, it will cause a lot of problem later on. Okay, so that's the thing that we need to impart, and we need to coordinate and arrange appropriate referral and appropriate we need to actually take appropriate help. You know, if we have like weight watchers for kids, you know, support group for parents, what to do if your child throw tantrum. Okay, they not want to eat what you cook now. They still want to have whatever that they used to have. What happen if your child said that they are still hungry? You know, so things like that. We need to think about, we need to change this family. We not change, we need to improve this family diet habit. That's what we want to impart to this family, because it's not only the child problem, it's the family. Okay, so it's not just like us, just see once and twice and that's it. No, this need long term. I mean, it takes time. Okay, continue, Raida.
Okay. So next we go to the assessment and also management. Okay, management lah, tadi kita dah assess kan. So basically this is the same. Okay, so for the after we assess the behavior, like what Dr. Rosnani said just now lah kan, the family, the structure family tu macam mana, family kita dah assess macam mana, and then kita boleh provide counselling using the 5210 just now, and then determine the weight classification, whether the child is overweight or terus obese lah. And then we can augment with the family history, review of the system, and also physical examination. And then we look at the risk factors. If patient had down into the red color, okay, so we need to take the blood investigation lah, macam tadi lah. Okay. And then if we suspect the obesity is related to the endocrine or genetic causes, so we need to manage accordingly. So this is the management and treatment strategy of patient or for children with overweight and obese. Okay, so kita kena start macam yang tadi juga, and then empathic and also empowering counseling styles such as motivational interview should be employed to support family and patient and also family behavior change. The main issue here is that we need to do the family counselling, because kanak-kanak, the child takkan makan kalau family member dia tak buat kan, ataupun tak ada income, tak ada duit daripada family. So the first thing first is the family behavior change kan, kita kena educate the parents ataupun family. Okay, so for the weight loss, we did not aim for the weight loss in the baby. Okay. And then the children also at the age of 2 to 5 who had obesity should not lose more than 1 pound per month ataupun 0.45 kg per month. Kita tak nak, actually kita tak nak the weight reduction tu is a bonus, tapi yang penting dalam for management of the childhood obesity is to maintain the weight. Okay, if the child can maintain the weight and with the height velocity, and the BMI will be reduced lah. Okay, because the child akan grow kan, so the height akan bertambah, tapi kalau kita boleh maintainkan the weight tu is good enough for the child. If we can get the weight loss is bonus lah. Okay, so there are 4 steps of strategy for the childhood with obesity. So the first one is prevention plus. Okay, we involve our primary care and also primary care providers lah. So we can plan untuk first of all, macam tadi juga, family counselling. Okay, counselling, we change the behavior. So the main management for the childhood obesity is the behavior modification and also activity. And then what our goals is to have the parents ataupun family itself to have a positive behavior change regardless of change in behavior. And then our goals also to weight maintains or decrease in the BMI velocity lah. Let's say kita dah buat prevention plus ni, dah bagi advice, dah bagi ni, and then kita buat follow up visit. After 3 to 6 months, still lagi tak achieve apa yang kita nak achieve, kita boleh advance to stage 2. So what is stage 2? Stage 2 is the structured weight management. Same according to, sama juga dengan stage 1. Okay, tapi kita bagi more intense support and structure to achieve healthy behavior change, which which is kita tak, bukan include kita sajalah, kita boleh include dietitian tadi, pegawai zat tadi, okay, our staff nurse as well, okay, in order same juga nak to achieve the positive behavior change. And then our goals also to have a weight maintains or decrease in BMI velocity. After 3 to 6 months, kita tak achieve apa yang kita nak, kita boleh go to stage 3, which is comprehensive multidisciplinary intervention. This one we can involve the pediatric team ataupun pediatric, kalau kat Kelantan ni pediatric endocrinologist lah, kan, pediatric endocrine, ataupun certain center they have obesity punya clinic, kan, for child and also for adult. So what are the comprehensive multidisciplinary intervention, which is we increase the intensity of behavior change, we increase the frequency of visit, and also specialists are involved. And then the structured behavior modification program, including foods and activity monitoring, and development of short-term diet, and also physical activity goals. Okay, and then we can so this frequent visit kita boleh buat weekly ataupun at least 2 to 4 weeks as determined by the patient, family, also physician. If we had a schedule follow up, if after 3 to 6 months still not achieved, we can consider to advancing to stage 4, which is tertiary care intervention lah. Okay, those who are expert in the treating childhood obesity. Okay, so we recommend for the children with BMI yang tadi severe obesity lah, ataupun yang tak sukses stage 1 until stage 3 yang kita dah give to the patient. Okay, and then our goals is to have a positive behavior change and decrease in BMI. Okay, this is macam just a macam picture to conclude that apa yang kita boleh advise pada parents lah, is ways to promote health with ni yang stage of preschool lah. Kan ada breakfast, ada childcare, ada ada outdoor activities kan, kalau hantar ke tadika tu teacher leads indoor and outdoor physical activities. Kemudian ada pergi market tu kita pick up the fruit and vegetables to cook for dinner. And then when visit kita akan check BMI, nutrition, physical activity, and then kena ada activity lah, outdoor punya activity. Okay, next, if berjaya juga, basically as far there are other medication juga, tapi basically we are not that happy to start with the medication lah kan. Tapi these two medication can be used in adolescent age lah, such as sibutramine or also orlistat. Okay, to be effective, this medication must be used in conjunction with diet and also exercise. Kalau tengokkan FDA approve the sibutramine for patient 16 years old and orlistat for the patient 12 years old of age. And
Aida, Dr. Mariam here. Just want to ask, sibutramine, is it being banned right now?
I'm not sure about that, doctor. Tapi so far,
Please check back, yeah, because there are
okay.
clarified of that. So just be careful.
Okay,
Thank you.
Okay, thank you, Dr. Mariam. Okay, and then the motivational interview. Okay, this is, I think, challenging part for the doctors. Okay, not for the patient, because we need to address the patient's ambivalence to change and focus on his or her values to resolve the ambivalence. Okay, okay, it must be. So I am sure that this motivational interview we must do like frequent lah, macam not only one visit, we have multiple visit lah. So kena buat berkala. Then scare tactic is not recommended lah. Kita tak boleh nak buat macam menakut-nakutkan anak tu lah, the child kan. The clinician has a role in educating family about the health risks associated with obesity. Tapi kita tak boleh nak bagi takutkan mak dengan ayah. Macam tu lah. Okay. Okay, next. Okay, we go to the next discussion. Boleh ke? Boleh ke semua? Boleh. Okay. Okay, this is a 6-year-old Malay boy was referred by staff nurse at KD. KD klinik desa lah for fracture and obese. A different situation dengan first case tadi. Okay, the patient born term via cesarean section with cord round neck and aspiration pneumonia, meconium. Patient was not crying during the birth and was admitted to NSU for a week. At 7 months old, he had pneumonia and respiratory distress and being admitted for that. At 3 years old, patient had history of seizures and has been started with anti-seizures medication. Noted also had undescended testes and undergone surgery but unsuccessful. Mother claimed that her boys had food-seeking behavior, especially when looking food at the kitchen from morning to night. He tend to had aggressive to others if anyone tried to stop him from eating. Maksudnya dia macam ada binge eating punya behavior. For developmental milestone, he had his speech and also intellectual ability was delayed. For family history, the boys was youngest out of 4 siblings. 3 were normal and no other history of disorder around the family. Okay, so clinically noted the boy was short and obese looking. The height is 105 centimeter and the weight is 27 kilos with the BMI of 24. Okay, if you see the picture, what the abnormality that you can see in the boy, in this boy? Anyone? Any takers? Ada siapa-siapa? Flat feet. Lagi? Soft dysmorphism. Lagi? Tak ada dah. Prayer. Prayer Willy. Prayer Willy. Small hand, yeah. Small hand, small feet. Sausage finger. Sausage. Okay, tak apa, kita go through dulu. Okay. Basically, the boy is 6 years old boy with short and obese, had history of seizures and hypogonadism. So basically, the boy ada upslanting palpebral fissures with the almond-shaped eyes, hypertelorism and mild strabismus. His hand and feet were small and had hyperphagia and also stubbornness behavior and also speech and intellectual delay. So based on the case, what is your diagnosis? Macam apa nama tadi? 5D. Betul lah, Prader-Willi Prader-Willi syndrome. Okay. So what is your plan of management? Okay, we go one by one. We go a bit dah on the Prader-Willi syndrome. Okay. So Prader-Willi syndrome is the most common syndromic form of obesity. Why I put this case? Because this is one yang macam tadi kita tengok constitutional obesity, yang exogenous obesity, tapi this is one of the contoh syndromic obesity lah. This is rare, but dia dalam community kita ada. Okay, ada dalam community kita. Okay. The Prader-Willi syndrome is not inherited and it occurs sporadically. And most common genetically identified cause of life-threatening obesity. Okay, the prevalence is 1 in 12,000 to 15,000 and both it affect both sex and also race lah. Okay. So what are the characteristics of Prader-Willi that we need to tackle? First, they will have a weight problem and also appetite disorder. They will have behavioral issues, they will have a developmental concern and also physical features. Okay, so the weight problem usually, so Prader-Willi, they have a feeding problems and also poor weight gain in infancy. Okay, masa kecil awal-awal tu dia akan macam small kan. low birth weight, low, and then diorang akan start ada diorang tak makan, and then diorang macam apa low lah, weight dia tak naik macam like normal baby. But at the age, after the age of 1 to 2 years old, after 1 years old, they will have hyperphagia, which is abnormally increased appetite for consumption of food. Okay, they will excessive and rapid weight gain between the 1 and 6 years old, usually started after 2 years old. And then if the absence of the intervention, they will have obesity in with food and also compulsive eating lah. Okay, so what is the next issue? Usually the Prader-Willi syndrome, the infant and children are typically happy and loving. Diorang sangat peramah. Okay, the older children and adults have difficulty with behavior regulation, and they are tantrum. They are usually easily get tantrum, and then they are stubborn lah. And then had obsessive compulsive behavior, and then most issues are food related.
What's your weight, Jan? What's your weight? 50 or 40? 50 what?
Okay, and then for the developmental, usually the baby hypotonia in infant, and then improve with age and also intervention lah, and then may create feeding problems and also delayed speech and deficit in strength and coordination and balance. Usually they will have a normal IQ lah, average IQ. And then they will have problems like attention, short-term memory, and also abstract thinking. Okay. Usually the growth hormone is normally deficient, so they will have a short stature, lack of growth spurts, and also high body fat ratio. And then the sex hormone is typically low, and however they have a good response to treatment and had early pubic hair lah. Okay. So this is the physical features of the Prader-Willi. Kalau kita tengok sekali nampak macam normal je kan. Tapi if we macam tengok teliti betul-betul, they are short stature, they will have long and narrow head at birth, narrow face, ada almond shape of eyes, small mouth, thin upper lips, small upturned nose, and also small hand and feet. Okay, kalau siapa pernah kenal Oki Setiana Dewi, dia punya anak yang keempat tu Prader-Willi syndrome lah. So currently under physiotherapy lah. Okay, so I will not go much on the Prader-Willi.
Dah operate dah pun. Dah operate dah first, nak operate lagi sekali masa umur setahun. Dia ada some
Dah terus lagi ada
Tahu saja.
Tahu
Kalau
saja.
kalau kita tengok sekali macam happy baby, macam tak ada nampak apa je kan. Tapi itulah Prader-Willi. So
Mata
kalau
dia tu nampak palpebral, up slanting, semua dia ada tu. Dia tu.
So kalau kita baca kisah Oki Setiana Dewi, masa mengandungkan Sulaiman ni, anak dia kurang gerak. Tapi CTG okey, tapi baby a bit macam kurang gerak, macam compared to other baby lah. Okay. This is diagnosis of the Prader-Willi syndrome. Nanti boleh baca. And then for diagnosis Willi, usually we use the methylation test lah.
It does, but this one is genetic obesity, so you have to treat the hormonal as well, right?
Yes.
Then
basically, yes. So because we already there's a few issues that we face with those who are Prader-Willi syndromes. So the management also there are multiple areas lah, like behavior issue we need to, because usually kalau kat Prader-Willi, kalau kita tengok pengalaman yang Prader-Willi yang dah besar-besar pun memang dia punya akan ada behavior pergi ke dapur makan, binge eating tu kan ada. So basically parents again family counseling, also education to the parents in order to avoid obesity in the Prader-Willi kan. So they have to macam kena ada routine and also structured lah, strict rule and limits to the Prader-Willi punya baby ni. So kita akan bagi structured punya makanan sebab diorang selalu akan lapar. So kita bagi makanan, limits, the snacking apa, and then time out, and also positive rewards to the if they able to follow family punya instruction tadi kan. And then for the weight problems, we had with problems, there are growth hormone replacement. Growth hormone replacement usually based kalau according to Dr. Rashida, growth hormone replacement ni we can give to the baby, to the Prader-Willi punya syndrome patient before the age of 1 year old, because we already know that growth hormone usually reduce in the Prader-Willi. So this growth hormone basically can improve the body consumption, reduce in the binge eating punya behavior, and also can help in the hypotonia of the child lah. Okay, tapi saya tak baca detail lah pasal growth hormone how many, tapi basically we can give the growth hormone lah as a for the treatment for Prader-Willi syndrome baby. Okay, with the weight control and the life expectancy is normal, and the obesity and diabetes common in individuals who don't follow their diet. Okay, so we know that those Prader-Willi can lead to the obesity, so can lead to the diabetes. So we can prevention is better than cure. So we need to control the obesity among the Prader-Willi punya baby. Okay, with a strict diet and also lifestyle that may be stressful to the family. So we need to give counselling, education, and in Malaysia we have a support group which is Persatuan Sindrom Willi Malaysia lah. So basically ramai lah Prader-Willi baby kat Malaysia ni. Semua kita tak alert lah. Macam saya pun tak alert, saya baru tahu bila buat this tajuk lah. Okay, so okay, and then the other is the hypothalamic obesity. Hypothalamic obesity is usually those hypothalamic lesion that cause the rapid progressive severe obesity, and it's particularly difficult to treat. Basically, the hypothalamic obesity arise after surgical treatment for craniopharyngioma and usually associated with panhypopituitarism. And then similar pattern may be caused by trauma, tumor, or inflammatory disease affecting the hypothalamus. So the lesion that arise from the ventromedial hypothalamus and also paraventricular nucleus can cause uncontrolled voracious appetite leading to severe obesity. Okay. Okay. So I think that's it. This is just because we might face the obesity, childhood obesity later in our life. So kita kena bezakanlah sama ada the obesity is idiopathic ataupun endogenous. Okay. Sama ada environmental punya that leads to the obesity, the genetic caused obesity, the endocrine like Cushing syndrome that leads to obesity. So there are difference lah between that. Okay. Just a short note from me that short and obese, they always think about genetic syndrome and endocrinopathies, and because the exogenous and notional obesity usually they are tall and obese lah. Alright, I think that's all for me.
Okay, thank you. You all nak take 5 ke? Nak masuk balik untuk yang Chia punya? Mar, kita nak take 5 ke?
Depends. You can, I think, can continue.
Okay, so
boleh, depends.
Boleh Dr. Rose take 5.
Saya tanya dah lama, so kita take 3. Kita start 3, 2, 5 nanti dengan Chia, okay?
Okay.
boleh unshare?
Dr. Yaakob, if you have any question, you can ask or you can type in the chat.
Okay, thank you, Doctor.
Can we start?
Please, Chia.
Okay, good afternoon, Dr. Rosnani, Dr. Mariam, all lecturers and my colleagues. So I'm Chia. I will continue with the second part, the handling of failure to thrive in primary. So it will be a case-based discussion, two more common cases that we see in clinic kesihatan. So I just start with the case number one. A 1 year, 2 months old girl, full-term SVD with the birth weight of 3.25, length 50 centimeter, and head circumference of 35 centimeter, which are all within the normal range. This girl was referred by the nurse for kurang berat badan teruk with the latest weight of 6.6 kilo, which is just below the -3 standard deviation. But the length and the head circumference are in the normal range. So this girl is immunized up to age, no previous hospitalizations, no known medical illness. And the mother claims that the child is active, while at home, there's no other symptoms. No other hereditary diseases running in the family. So further history, the child is taken care by her grandparents during the daytime because the parents are teachers. She's the only child, there's no financial issues. And the child is taking 3 main meals per day. The mother thinks that the child has no issues with eating and she is not a picky eater. And on examination, the child is active, no dysmorphism, pink, cheerful, hydration good, the cardiovascular and respiratory unremarkable, and there's no hepatosplenomegaly. So these are her growth charts. Anybody wants to comment on the growth chart for this girl?
Hi, Chia, can I try?
Yes, thank you,
Okay,
Ngu.
so on the left side is actually the weight for age. So initially, when she was first born, it was actually normal in a white zone. But as her age progressed, it actually crossed 2 centile lah. Currently, I'm not sure. I think it's just a borderline or Wait, let me see.
Yeah, it's just a borderline,
border,
just
okay.
at the line of the -3 standard
Okay,
deviation.
and minus
Okay,
of 3 standard deviation. And but then, however, for the height for H is actually, it was actually normal growing lah. So in this case, yeah, So
okay,
I think it's a poor weight gain code with a normal height for H.
okay. Thank you, Ngu. So yes, correct. For the BMI, is also similar to the weight. Is crossing the to the red zone, which is below the -3 standard deviation. And for the head circumference, is rather in the normal zone for this girl. So what is your impression? Is this an underweight, wasting, stuntings, or failure to thrive? Anybody wants to tell their impression, his or her impression?
Or maybe I'll just continue.
Okay.
Because it's just the weight only, right? So I think more towards crossing almost 2 centile, maybe failure to thrive.
Okay, thank you, Ngu.
Underweight also lah.
Okay, so is it underweight or failure to thrive? We will go through together later. So before I go to the definitions, a bit on the normal growth. Growth, as we all know, is the most important indicators of health in children. And normal growth is the progressions of the changes in the weight, height, and head circumference that are compatible with the established standards for a given populations. So this table is taken from the PITS protocol. It just gives a rough idea of what's the rough weight, head, height, and the head size for the age group. But the more applicable to us may be this average weight gain per day. So as we can see, the maximum weight gain is during the 0 to 3 months old, which is about 30 gram per day. It will drop slightly to 20 gram per day from 3 to 6 months, 10 gram per day to 6 to 12 months, 7 to 9 gram per day from 1 to 3 years, and 6 gram per day for 4 to 6 years. So this average weight gain is important for us to monitor the weight gain, especially for poor weight gain children. How about the height or the length increase? There's actually 4 phases of growth in terms of the length. The first one is the fetal phase, which accounts for the 30% of the adult height. It is influenced by the uterine environment. The second one is the infantile phase, which accounts for the 15% of the adult height. It is influenced by 3 important factors. The most important one is the nutrition. Always think of nutrition. The second is good health and happiness, and the third is thyroid hormone. And this is the time that we always follow up quite frequently for our infants in the clinic kesihatan. So we have to make sure these 3 factors are being optimized for the optimal growth. And the third one is the childhood phase, which accounts for the 40% of the adult height. It is influenced by the growth hormone, thyroid hormones, the genetics, as well as the good health and happiness. And last is the pubertal phase, which account for the last 15% of the adult height. So there are many myths among the parents. They think that their children might start to gain more height at the onset of puberty, which is actually wrong, because at the onset of puberty, their final height, adult height, is already determined, because in girls, she can only gain about 8 centimeter, and for boys only can gain about 10 centimeter at the onset of puberty. So for us as a primary care, we need to tackle earlier in the infant and the childhood stage. Okay, so we come back to our definitions. So Rohaida just now already discussed about overweight and obesity. So for undernutrition, there are actually 3 different definitions. This is just a figure illustration. So first one is underweight, which is defined as the weight for age less than -2 standard deviation. The height for underweight child could be normal or slightly shorter. Second is wasting, which means the weight for the height less than -2 standard deviations, which means the child is thinner to his or her height. And the last one is stunting, which means the height for age less than -2 standard deviations. For stunted child, the weight could be underweight, normal weight, or overweight. And how about the prevalence of undernutrition in Malaysia? So according to the latest 2019 statistic, actually all 3 undernutrition prevalence is increasing, with stunting actually is the most significant, from 17.7% increase to 21.8%. However, in today's my discussion, I will focus more on the weight problem rather than the height problem. So we already discussed about the underweight. So what is actually failure to thrive? It means that it is an inadequate weight gain over time, and it is used to describe findings, and it's not a diagnosis. According to UpToDate, we should avoid the term failure to thrive because it is ambiguous. Instead, we should use the term poor weight gain or weight fattening or growth fattening preferred because all referring to failure to gain weight appropriately. And AAFP 2016, their guideline also mentioned weight fattening is proposed to be a more appropriate term because inappropriate weight gain is the initial and the most reliable clinical findings of undernutrition. With the ongoing severe malnutrition, eventually the overall growth will be affected. First will affect the weight, then the length, then the head circumference, and if still uncorrected, even the development and the cognitions of the child will be affected. So first must tackle if there is poor weight gain, we must tackle it. And is there any definitions for poor weight gain or weight fattening? It's actually, there is no consensus definition. But in UpToDate, they use the working definition as the weight for the age and the sex less than second percentile or less than -2 standard deviations together with a decreased velocity of weight gain that is disproportionate to the growth in length, which means we have to plot on the weight for height chart. But in clinical kesihatan, we don't have this chart. So we are using the other two indices as proposed by the UpToDate, which is weight for age and sex less than second percentile or -2 standard deviations on more than one occasions, or the rate of weight change decreases 2 or more major percentiles. So these two the two definitions that we commonly use in primary care setting. The other indices could be weight less than 80% of ideal weight for age and the rate of daily weight gain less than expected for age. Okay, so so far any questions? Okay, if no, so there are actually, yes?
For the failure to thrive, does it says any has to crossing centile or we just not?
Actually, failure to thrive, according to UpToDate, is
Yes.
similar to poor weight gain. Yes, have to be crossing 2 or more major centiles, or is more less than -2 standard deviation on more than one occasion. Either one could be can use for the definition.
Yeah, thank you.
But it has to be more than one occasions. It has to be over the time. Okay, Ngu?
Okay.
Acha, you said that it must be more than two occasions,
More than
right?
one occasion.
Sorry, more than one occasion. How long apart?
There is actually no proper like definition how many apart, but usually we will monitor monthly, right? So if after 2 months still more less than -2, then we actually should pay attention to it. Okay.
Okay, thank you.
Okay, so for the growth chart, there are many growth charts available. That the two common growth charts that we are using are the WHO chart and the CDC charts. So the CDC recommends that for 0 to 2 years, we should use WHO chart, and more than 2 years old, actually CDC chart is preferred. Why is it so? Because WHO chart is also known as the standard chart. It is developed using international populations involving the breastfed children. So it can reflect how a children can grow under an optimal environment. Whereas the CDC chart, why use after 2 years old? This is because the methods used to develop the charts for the WHO and the CDC chart after 2 years old, the methods used are the same. And the other benefit is the CDC chart can be used continuously from 2 years to 19 years old, but the WHO chart only used up to 5 years old. But in Malaysia, in our clinic kesihatan, the buku record, we are actually using the WHO chart. As we know, the WHO chart, there are different charts for the boys and for the girls, and there is different charts for the age groups. And if you notice, there's actually two different types. One is sex score in the standard deviation, and the other one in the percentile. So is the -3 standard deviation similar to the third percentile? It is actually no. If remember the normal bell-shaped distribution, -2 standard deviation is roughly equivalent to 2.3 percentile, and -3 standard deviation is roughly equal to 0.1 percentile. So, and a third percentile is roughly equivalent to about -1.8 standard deviation, which means if we are using the percentile chart, if the child is below third percentile, it's almost roughly already fulfilling the -2 standard deviation. But in Malaysia, we are actually using the standard deviations. So this one, we all quite common using this. If we see in the white color zone, then we will say that it's a normal zone. If it's in the yellow zone, then it's a KBBS or the kurang berat badan sederhana. And if it's under the red zone, it's called the KBBT, kurang berat badan teruk. And usually the nurses will refer us if it's crossing to the yellow and the red zone. And recall just now, if it's a failure to thrive or poor weight gain, it's either in the yellow zone for more than one occasion, or there is a crossing of 2 major percentile. Okay, so come back to our case just now. As Mu mentioned, it's already in the yellow zone for more than one occasion. So this is a case of poor weight gain. And is there any history and any physical examinations that you would like to ask other than the one that I already mentioned just now? Maybe Nadira, do you want to try? Nadira, are you there? Or Shakina?
Diet history.
Okay.
Diet history tu I would like to ask regarding apa macam kalau dia minum susu ke berapa banyak dia minum susu, lepas tu dia punya intake amounts of intake dia, karbo berapa, protein berapa. Lepas tu nak tanya dia punya exercising dia, lepas tu dia punya birth history, macam ada pram ke apa ke sebelum ni.
Okay, thank you, Shakina. Kimi asked about any growth chart for premature baby. Yes, there's actually premature baby special, the growth chart for premature baby, or we can use the corrected age chart. Okay, Shakina, thank you, Shakina. So basically, when we evaluate it, our aim is to find the cause. Yes, correct. As Shakina mentioned, the most common cause is the diet, the nutritional part. So there are 3 potential causes of failure to thrive. There are 3 main ones, which are the inadequate calorie intake, inadequate nutrient absorption, and increased metabolism. The one that we commonly encounter in primary care would be the inadequate calorie intake. So the causes could be like GERD, inadequate breastfeeding, incorrect formula preparation, mechanical feeding difficulties like the cleft lip or palate, child neglect or abuse, poor feeding habits, or poor oral neuromotor coordinations, and any toxin-induced GI upset. Whereas the inadequate nutrient absorption, it could be like IDA, biliary atresia, celiac disease, irritable bowel syndrome, cystic fibrosis, inborn error of metabolisms, or milk protein allergy. And increased metabolism could be in any chronic infections and inflammations, like the lung disease, congenital heart disease, hyperthyroidisms, asthma, malignancy, and renal failure. So our history should target on all these different, we can find the cause and correct accordingly. So the first thing we should ask is, we will go through together, is the onset of the poor weight gain. Either we can ask the mom when she noticed the poor weight gain, or we can get it from the serial growth chart. So this one is from up to date. Based on the age, actually most of the time, as I put in the red bracket, most of the time the cause is still nutritional cause. But there are certain things like congenital heart disease, cystic fibrosis will occur earlier in birth to 6 months, and cystic disease, celiac disease will occur in older age. So this is just a guide, maybe can read on it on own. So other than the onset, we must get a detailed diet and feeding history. So as Shakina said just now, we are not only asking, is it okay with the feeding? We should ask very specifically. Like breastfeeding infant, we need to ask how frequent does that the mother feed the child, how long each duration, is the milk production adequate? Like, can the mother hear the infant swallow? Does the baby have a strong sucking? Does the mother feel the sensation of lap down? How is the conditions of the mother? Does the mother feel stressed or fatigue? Similar to formula fed infants and older children, we need to ask very specifically frequency, duration, the texture, And also the general aspect, like is there any vomiting, any stool pattern change with the feeding? Is the baby having difficulty with feeding might indicate a cardiac or the lung disorders. Not to forget, have to ask about the feeding environment as well as the any in difficult feeding behaviors. So this one I will not go deep into it. Maybe can read on own later. So other than the feeding history, past personal medical history, including antenatal, postnatal, any medical condition, especially like atopy, food allergies, any gastroesophageal reflux symptoms, UTI symptoms, family medical history, particularly any hereditary problems like celiac disease, inflammatory bowel disease, cystic fibrosis, the parental any parental malnutrition during the childhood, asking about the parental height and the parental age at puberty, maybe can give us an idea. It could be a genetic short stature or constitutional growth delay, as well as any psychiatric illness or substance abuse in the caretaker. Next is the social history. So we need to ask about the living conditions. Who is the primary caregiver? How is the caregiver and the child relationship, and any stressor in the family? We mainly need to find out, is there any poverty, any food insecurity, any poor parental skills, could be any child neglect or abuse. And last but not least is to review the systems from head to toe. Is there any chronic recurrent infections, any GI symptoms, any other symptoms that we can think of which is the cause of the failure to thrive. So after thorough history, we need to do a physical examination. For physical examination, the goal is actually to find out, is there any systemic or any genetic problems. For example, we can look at any dysmorphism and from head to toe systematically, we check for the hearts, any murmurs, for respiratory, any signs, then hepatomegaly. And not to miss, we should check, is there any, could be a child abuse sign, like any bruises or any scale or any burn mark in suspicious area. All this we can, that's why we need to expose the child during the physical examination so that we do not miss the possible child abuse. Okay, so we come back to our case number 1. So the girl, remember just now, 1 year, 2 months old. She was taken care by the grandparents after 4 months old as the parents are working. So for the feeding history, she was breastfed exclusively until 4 months old. She was on formula milk subsequently and weaning at 6 months old. With the porridge mashed with chickens and broccoli. The porridge was prepared by the grandmothers. So according to the grandmothers, it's not the thick porridge, but it's rather a watery type, about 2 times per day, each time about 4 to 5 spoons. So together with the porridge, the child will take the formula milk about 1 bottle a few times per day. Then started to give the thick porridge with the chopped chickens and vegetables at 1 year old, taking about 3 times per day, half bowl each. Used to take formula milk about 4 ounce or orange juice 1 cup before the main meals. Systematic reviews and the developmental examination unremarkable. So with that, is there any test that you want to take for this girl as already in the yellow zone and crossing to the red zone, the latest weight? Anybody wants to try? What investigation that you want to take? Fidaus ada tak?
Hello?
Fidaus.
Hi, sorry. So, for this, can we go back to previous slide, sorry, Chia? Okay, social taken by guys. So,
So basically, she has no other symptoms, just that the feeding might be some problems there. So will you take any blood test or any investigation?
So for the first time, I will not take any lab investigation lah. But let's say that
But this is not the first time, Fidaus. This is the growth chart for the girl.
Okay. Okay. For me, there is no need. Just monitor the weight first and including the age, and then let's say that is more deteriorate, then I will take maybe FBC to rule out is there any IDA or any possible anemia like thalassemia.
Okay. Thank you, Fidaus. So there is no standard definition when we need to take and what we need to take. But according to the AAFP 2016, the guide, it recommends that if we want to take initial blood tests, the reasonable test that we can take includes FBC, like Fidaus mentioned just now, mainly to look for any anemia, any infections. Then we can take a renal function electrolytes, LFT, to look for any systemic diseases. Then thyroid function test, as remember just now, our growth chart during the infant and childhood thyroid functions is very important. So we need to make sure it's not a hypo or hyperthyroid. Then urinalysis to look for any UTI. So for this girl, somehow all this investigation was taken and it's normal. Other than this initial lab test, there are other additional testing, but it depends on case-to-case basis. It depends on what we gather from the history and examinations. If we suspect chronic infection inflammation, then we can take CRP, ESR. If there is a chronic diarrhea, then we can take the stool, OVA, and cyst culture. If there is a cardiac or pulmonary symptoms, then we order the chest X-ray. If we suspect celiac disease or malabsorption, then we send the tissue transglutaminase to reducing substance, and sweat chloride test if we suspect cystic fibrosis presented with recurrent respiratory symptoms, or HIV, and mental test if needed. So for this case, we didn't proceed with this additional testing as there are no any feature suggesting of these causes. And now, so what are the most likely diagnoses and what is the next steps in management? Due to time constraint, I will just proceed. So actually, as we call this just now, this girl actually already 1 year, 2 months old, but she's still being given a porridge, and she has not started to eat adult food, and she is taking a formula milk and the orange juice before the main meal, which actually for this girl is inadequate calorie. So these are the management in the klinik kesihatan. She was referred to the Pegawai Sains Pemakanan. Detailed diet history was obtained. The parents were counseled to increase the frequency of the meals and emphasize on the textures of the food appropriate to the age. Syrup multivite was started. The mother was encouraged to add the margarine, olive oil, or butter in the cooking. Advised to feed the solid food before the beverage, and a TCR of 2 months was given. So this is her progress after the advice. It started to have a catch-up growth, although still in the yellow zone. So is there any other indications for hospitalization? So these two from the AAFP and up to date, these are the indications, which include extreme caregiver impairment or anxiety, extreme poor caregiver-child interactions, where the precise documentations of the energy intake is required. There is failure to respond to our treatment, outpatient treatment after several months, where the child is at risk of harm, like if we suspect child abuse, and there is a severe malnutrition, where the weight for age less than -3 standard deviation or BMI less than 12, significant dehydration, serious intercurrent illness or significant medical problems, or if the outpatient management's the TCA is impossible. For this case, although it's touching the -3 standard deviation, but there is no other indications for hospitalization, and the child is relatively well, so we just monitor outpatient. This is the management for general failure to thrive or the poor weight gain children. Most of them can be treated in outpatient setting, and a multidisciplinary approach should be applied, which involves the primary care physicians, the dietitian, nutritionists, the nurses, and etc. And the mainstay of the treatment is nutritional therapy, and the goal is to catch up weight gain. So remember just now this table, the average weight gain that should be gaining for the age groups. For the weight gain to occur, it has to be 2 to 3 times of the expected weight gain. For example, our case 1 is 1 year, 2 months old. So average weight gain for her would be around 9 grams. So for the catch-up to occur, it must be at least 9 multiplied by 2, at least 18 grams, roughly about, if taking 20 grams, roughly 1 month needed about 600 grams for the catch-up to occur. So there are 5 components under the nutritional therapy. We will go through it. So first is to estimate the energy requirement. So we must first estimate the energy requirement, EER, which is the energy required for children who are not undernourished. This is the table of the EER for different age group. Then we have to calculate what is the daily requirement for catch-up growth. This is the formula. And we have to use the EER multiplied by median weight for the child's current length divided by the child's actual weight. So what is median length for current weight? We need to first obtain the weight for length chart in percentile. Then we plot the weight and the length. We will get the point A. For example, 9 kilo with a length of 78 centimeter, we will get the point A. From point A, we draw a vertical line to the 50 percentile curve, we will get the point B. From point B, we draw a horizontal line to the weight scale, we will get the point C. And point C is the median weight for the length. So after we obtain the median weight for length, so the example is 15 months old, so the EER will be 83 kilocal. The daily requirement for catch-up growth using the formula, then we will get 95.5 kilocal per day. So this is the calorie that we will ask the, we will roughly divide the kilocal needed, then ask the parents to prepare the food according to the kilocal. And we adjust based on the energy requirement from the growth response. But this is a bit time consuming and usually we do not have times in clinic. So we always can refer to the dietitian or the nutritionist and ask them to help us to calculate this. So other than the calculations, the one that we can do, we can always prescribe the multivitamins. It should be containing iron and zinc. And if the multivitamins does not contain the zinc, a zinc supplement of 0.3 mg per kg of elemental zinc should be provided. Third is strategies to increase the calorie intake. Before we tell the parents about strategy to increase intake, we must first make sure that parents are doing correct according to the age first. So as we all know, we have to encourage the parents to exclusively breastfeeding until 6 months old. Even though can continue breastfeed until 2 years old, the parents must start to give complementary food to the children at 6 months old. And this is the table taken from our Garis Bantuan, Malaysia. So approximate numbers of milk given to birth to 1 month is 8 times, 1 to 2 months is 7 times, and from 2 months onwards is 6 times. And for complementary food, as remember, must started at 6 months old. And 6 to 8 months, we usually will recommend 2 to 3 times of complementary food with 1 to 2 times of healthy snack. From 9 to 11 months, 3 to 4 times with 1 to 2 times of healthy snack. And 1 to 4 years, it should be 4 to 5 times of main meal together with 1 to 2 times of healthy snack. So just now the case number 1, the girl 1 year, 2 months old, she's only taking 3 times main meal per day. So for her, she should take at least 4 to 5 times of the main meal together with 1 to 2 times of the healthy snacks. Other than the frequency, know the normal frequency, the textures. So now we can advise the parents the strategies to increase the calorie intake. So for example, those that commonly taken by the child, maybe we can ask the parents to mix a bit of the nasi dengan nasi, bubur nasi digaul dengan sedikit minyak atau margarine, roti disabur margarine ataupun mentega kacang ataupun keju atau dicelup dalam telur dan digoreng. Untuk biskut disabur margarine, mentega kacang keju, telur digoreng dengan minyak atau margarine. And susu ditambah dengan gula atau serbuk coklat macam Milo. We can give a few examples, but for further advice, we can always refer to the dietitian and nutritionist. They will help us to give the plan, specific plan according to each child. And next is about feeding environment. We should ask the parents try to eat together as a family. Make sure that the child can reach the food, maybe can use the high chair. The caregiver should encourage but not force the child to eat. The child should be praised when they eat well but not punished when they do not. And the distractions to the mealtime should be minimized. For example, TV, screen, all those should be away from the dining table. And the last one is other dietary advice. They have to have a consistent schedule. The snack should be timed so that the child's appetite for the main meal will not be spoiled. And during the main meal, offer the solid food before the liquid. And if to give liquid, the beverages like fruit juice or carbonated drinks, limit to 120 ml per day. Okay, so after we all this advice, we must always give the TCA. So it can be weekly to monthly, depends on the severity of the child. And what is a definitions of successful response to initial therapy? It is defined as there is a catch-up growth, which is 2 to 3 times of the normal average weight gain for age. Even the child gain back the normal weight, it should be monitored at least 6 monthly for at least 1 year to ensure that the normal growth rate are maintained. And from the latest symposium, the Kelantan symposium by Dr. Rashdan, she actually encouraged to continue monitor up to 4 years old to make sure that the child's in the optimal conditions for growth. Okay, that's all for case number 1, which is about the inadequate calorie intake. Is there any questions?
Sure.
If no,
I just
sorry.
one question. So you ask the patient, why is it they give the formula milk before the main meals? Is there any misconception? Something? Why the grandparents give the child formula milk before the main meals?
Oh,
Is there
they
any
thought the
misconception
formula
there?
milk. Sorry?
Do
Sorry,
you
Dr. Mariam.
explore? Do you explore in further why
For
that
the case
happens?
number 1,
Yes.
yeah, because the grandparents thought that the formula milk is more nutritious.
Oh, okay. So it's like misconception. So you have to listen to
Misconception.
feedback there. Okay.
Yeah, because the main caregiver is the grandparents.
Okay.
Okay, so we go to case number 2. A 10-month-old boy is being referred by the nurse for poor weight gain. He was born full-term SVD with birth weight of 3.1 kilo. He was healthy with no other medical problems. The mother decided to stop breastfeeding as she starts to work and switch to formula milk at 6 months old. The boy tolerated the formula milk well initially, but started to develop rashes over the cheeks and tummies 1 week after started on formula milk. The boy also seemed to be agitated during the feeds and during the night. The mother has underlying bronchial asthma with eczema, and father has underlying allergic rhinitis. So the mother has brought the child to the GP, was treated as heat rash and eczema with topical cream, but the rash did not improve. And since 6 months old, the child was fed with porridge and formula milk 4 to 5 times a day. The mother also noticed that the child on-off passing loose stool, but there is no blood in the stools, and frequently waking up crying in the night. The rash persists despite multiple GP visits. And the mother read in the Google and she tried a goat milk at about 9 months old. The condition improved for a short while, but recurred and persists until now, which is 10 months old. So on examination, the mother is very worried about the child's eczema. The child is fretful, eczematous rash over the cheeks, flexures noted, other system unremarkable. The developmental assessment is appropriate to age and the growth chart is as shown. Anybody wants to comment on the growth chart? Ain ada? Muriato Ain? Atau Siti No Ain?
Okay. Sia, can you hear me?
Ain. Can you comment on the growth chart?
From the growth chart, we can see the height for this child is normal, growing well, but the weight, we can see there is
Maybe it's a bit small, right? Yeah.
there is deteriorating from the 7 month to the 9 month, right?
Yeah,
And then,
thank you. Yeah.
So from this there is poor weight gain, and subsequently from the 8 to 9 months there is some sort like static, and then this cross the 2 centile.
Okay, thank you so much, Ain.
Okay.
Yeah, it's
Okay.
as I mentioned, the height is normal, but the weight started to be settling after about 6 to 7 months like that. So, what is the most likely diagnosis after knowing the history and the examination and looking at the growth chart? And what is the next steps? So I will just go to the next one. So because this all started after the mother changed to the formula milk, and even though she tries the goat milks, it still but recurs. So thinking of that, a possible cow's milk protein allergy is suspected. So the possible diagnosis is being explained to the parents about the possible presentation, including the anaphylaxis presentation, and that if there is anaphylaxis. So the case was referred to the PITS team for confirmation tests, and it also referred to the dietitian for diet education. TCA of 1 month was given. So seen by the PITS team, open oral was put Olive's formula, avoidance of the cows, and after 1 month in persistency of formula to be happier at the mealtime and the weight pickup. So the plan by the PITS team is to re-challenge of the cow's milk protein every 6 months until tolerance occur. Protein allergy is hypersensitivity to the cow's milk protein. It is the most common food allergy in the young children. So it could be presented with GI, cutaneous, respiratory symptoms, and a small percentage, 9%, may experience anaphylaxis. And most of the time, majority of the children will resolve by the age of 3 to 4 years old. So it could be of IgE-mediated reactions, which is immediate within 2 hours after ingestion, could be urticaria, angioedema, anaphylaxis, or it's a mixed presentation, like the atopic dermatitis, eczema presented in this case, or non-IgE-mediated reactions, which are the delay onset of presentation after 2 hours of ingestion. It could be of gastroesophageal reflux, gastroenteritis, proctitis, proctocolitis, or just a loose stool, the enteropathy, like in this case. But remember as mentioned, the gastroesophageal reflux, if we encounter patients with GERD, which are not responsive to usual advice, we actually have to think of cow's milk protein allergy. How do we diagnose a cow's milk protein allergy? By history alone, we cannot diagnose it. So we need to do a diagnostic testing, which is the first line would be the gold standard is the double-blind placebo-controlled food challenge, but it is not always done because it is has to involve a few visits and it is time-consuming, where both the doctors and the patients are blinded, which means they are not sure when the placebo is given and when the allergens is given. Whereas the open oral food challenge is usually more practical and is more commonly practiced. Open oral food challenge is where both the doctors and the parents know that the allergen is being given. It is done in a single clinic visit where increasing dose of that allergen is given in increasing dose. So the child will be observed for the reactions about 3 hours after the allergens given. But if the test is not possible, a skin prick test can be done. When the wheal diameter more than 6 mm in less than 2 years old or the 8 mm in more than 2 years old, we can say that it's a cow's milk protein allergy. If it's both the food challenge test and the skin prick test cannot be done, then the serum cow's milk specific IgE test can be done. A level of more than 15 is a predictive of a positive diagnosis of a CMPA. So regardless of the type, eliminate the dietary CMP is the key. So the managements avoid the cow's milk protein in the form of oral, inhalants, or any contact forms. Have to substitute with the alternative protein. The first line is actually extensively hydrolyzed formula. If it's not tolerated, then we can change to amino acid formula or the soy-based formula. But it has to be a case-to-case basis depends on the child's preference, depends on the affordability of the parents, because all these formulas are much expensive compared to the normal cow's milk. But the goat's milk base or the fresh goat milks are not recommended, as there is a cross allergic reaction like the cow's milk. But there are actually many brands in the market. If parents ask what brand to recommend, maybe we can refer to the dietitian or the nutritionist for better advice to the parents. If we avoid it, we must monitor the resolutions of the allergy. We must check the cow's milk, check for the tolerance every 6 months with the open oral food challenge. If after the challenge there is no symptoms during the challenge and maintain no symptoms up to 1 week after the challenge, the child can resume the cow's milk protein in their diet under the supervision. But if the symptoms reoccur, then we should change back the child to the cow's milk protein-free diet and then repeat the re-challenge every 6 months until tolerance occurs. And last is about anaphylaxis management, but I will not talk in deep, but the mainstay is adrenaline if it's anaphylaxis. So is the CMPA similar to lactose intolerance? It is not. Lactose intolerance is due to the lactase deficiency. The trigger is lactose. Although lactose is commonly contained in the milk, including the cow's milk, it can be found in ice cream, yogurt, cream, white pasta sauce, and the soft cheese. The symptoms, it could be the same. The GI symptoms could be the same, but it will not have the IgE-mediated symptoms like the rashes, eczema. It will not have all these IgE-mediated symptoms. The diagnosis is by the lactose breath test, and lactose intolerance compared to the cow's milk protein allergy, it is rare in children less than 2 years old. The treatment is low lactose diet, and it is usually irreversible. It will be a lifelong condition. Okay, so that's all for the case number 2. Due to time constraints, there are a few more topics that we raise discussion. So far, we already discussed about the nutritional. As we can recall back, for nutritional, most of the time, the height will be normal, but the weight gain will start to have some fattening, starting about 6 months during the age of weaning. But we didn't touch about if the weight gain starts to be fattening about 4 to 5 years old, which is at the later age. If this is the case, most of the time it could be nutritional or it could be a chronic illnesses like asthma, celiac disease. And I didn't cover about on the left is normal. The height is falling off the centile. This is a case of stunting or short stature. It could be of a lot of causes. But in today's lecture, we didn't cover about it. But we actually can go to the YouTube on the last reference, which is the talk given by Dr. Rashdan recently 2 weeks ago about the approach to the child with short stature, where he actually had explained in detail about short stature. And last, if we have already checked everything, and where the height and the weight is along the third within the mid-parental height, then we can say that is a case of familial short stature. So that's all. These are my references. Is there any questions?
Yeah, Izam here. Want to ask one question. Saya dengar ke?
Hello?
Can child with lactose intolerant presented with failure to try?
Can. If it's very severe, tapi most of the time, less than 2 years old, it is not common to have lactose intolerance. Is there any other question? If no, that's all from me. Thank you so much.
Okay. The other one case that you have to for also in health clinic Kesihatan, if there's toddler come with fail to thrive or poor weight gain, then how you approach and how you manage the children, yeah? It's quite common here. Okay, And no question for Chia?
I thought
The mature baby as well, if you're in...
both of you do the KFQ and SBA? No.
Already removed, doctor.
Already removed.
I thought due to time constraint tak sempat. Rohaida ada ke?
Tak ada juga, dah remove juga.
What I want to say is that the failure to thrive, the obesity is a real challenges, okay, in our community, even currently. In terms of in your examination, you will have it either in your writing or in your clinical, okay, because this is among things that we need you to be coordinator, and also we want to see your comprehensiveness, because it will involve, like, it's not only the child, it will be the parents, their lifestyle, a lot of other things, okay. And then, like your friend said, to take blood investigation, you know, in a child. One thing is sometimes their vessel, especially if they're obese, it's really deep down and it's quite difficult for you to take the blood. And the other things, parents sometimes seeing or their child crying and telling them that they want to have the blood taken anymore because it's so painful or whatever, it will impact the parents. And sometimes that's the reason why they actually defaulted. You know, we don't want to have any more blood taken. We don't have to, because they see it just like, they will question themselves whether am I doing the right thing for my child? He's not that bad. He's only obese. Why do I need to go, you know, to undergo all this? Why did he need to undergo all this? So sometimes the motivation, the explanation is really important, and we need to actually keep reminding and keep asking them whether they have any question or they have anything to share with us. Okay, we need to be patient and we need to be persistent. Okay, any other last thought? I saw Prof. Nani just now, or did she left?
Yeah, correct. The misconceptions, especially for parents. They thought the obese child is good.
Yes, because I mean, I don't know about in Nigeria, but in Malaysia, people above 60, when they see kids, you know, obese kid or overweight kids, they call it sihat or healthy. Sihatnya, you know, just like for them, that's how kids should be. Chubby, you know, with bow leg a little bit and have fat all over. But when the child started to getting into teenagers and early adulthood, this is when the body image, the negative, the body shaming will come about. Okay, so that's why we need to educate and campaign about you know, healthy weight gain, healthy weights even from childhood. Okay. So no other question, no other thought from friends? If no, then we can finish this session.
I just want to add that in our country too, it's also similar. The belief is similar, particularly at the infancy. Everybody
all right, okay.
The children to look choppy a little bit, especially those that are still breastfed. During the first 6 months of life, if there is no underlying problem, usually they will look, they will have enough, they will grow well and the weight will be adequate. And unfortunately, when children, because childhood obesity, as you experience here, is also what we also experience in our country too, they don't see it as a problem unless there is underlying problem that is, for example, a child that has Cushing syndrome. That one will be obvious because there are other obvious illness that will make the parent to really want to seek help. Aside from that, if you talk about the only obesity alone, without having other complications, the parent will not really take it serious, and they are usually lost to follow up. And we see that as a sign, even in adults. There's even a saying that is the person that have the pot belly that has money. So it's not a sign of affluence everywhere. Even in adults, except when there are no problem, when they cannot eat, when they climb a stair and they start panting, move a few meters, they start having issues. So that is basically the experience is the same globally.
So yeah, we need to actually keep promoting healthy weight. You know, healthy weight, not too thin, not obese, healthy weight. But then this healthy weight is quite arbitrary, like you said. In certain community, healthy weight is like that. So we have to go with a clinical, what we call it, clinical healthy weight, what the consensus says are. Okay. So yeah, we still need to do a lot of campaign about this. Okay, so thank you very much, Dr. Yaacob. We will have another CME every Sunday at more or less the same time, 2:30 or 2:15. So with that, I think, and thank you very much, Dr. Rohaida, thank you very much, Dr. Chia, thank you very, very much, Dr. Maria and Prof. Nani. So with that, thank you very much. Assalamualaikum and bye.
Thank you so much, Dr. Rosani and Dr. Maria and all lecturers.